a 32-year-old female presents with progressive exertional shortness of breath and finger clubbing. I am showing you a coronal computed tomography pulmonary angiogram. Describe the findings.
The coronal computed tomography pulmonary angiogram demonstrates a well-circumscribed, lobulated, intensely enhancing vascular lesion in the right upper lobe.
State your primary diagnosis and the type of vascular communication present.
The primary diagnosis is a pulmonary arteriovenous malformation. This is a simple type of malformation, as there is a single feeding artery and a single draining vein.
If I tell you the patient has a history of recurrent nosebleeds since childhood and was recently admitted with a transient ischemic attack, what clinical syndrome must you suspect?
With that clinical history of recurrent epistaxis and a paradoxical embolic stroke, we must strongly suspect hereditary hemorrhagic telangiectasia, also known as Osler-Weber-Rendu disease.
Explain the pathophysiology of right to left shunting in this condition and its classic clinical symptoms.
The absence of a capillary bed between the pulmonary artery and vein creates a low-resistance right to left shunt. This bypasses the normal alveolar gas exchange, leading to arterial hypoxemia, which manifests as dyspnea, cyanosis, and digital clubbing.
What are the diagnostic criteria for hereditary hemorrhagic telangiectasia?
The diagnostic Curaçao criteria include recurrent spontaneous epistaxis, multiple mucocutaneous telangiectasias, visceral arteriovenous malformations, and a first-degree relative with the disease.
Approximately what percentage of patients with a pulmonary arteriovenous malformation have multiple lesions?
Approximately 30% of patients present with multiple pulmonary arteriovenous malformations, which are often bilateral and can range from simple to complex angiourticature.
How do you distinguish a simple from a complex pulmonary arteriovenous malformation on computed tomography angiography?
A simple malformation is supplied by a single feeding segment of a pulmonary artery and drained by a single vein. A complex malformation is defined by having two or more feeding arteries or draining veins.
Describe the key radiological findings of a pulmonary arteriovenous malformation on a conventional chest radiograph.
On a chest radiograph, it typically appears as a well-defined, round, or lobulated nodule in the upper lobe, with prominent tubular structures representing the feeding artery and draining vein extending to the hilum.
Explain why these patients are at high risk for developing a brain abscess or stroke.
The right-to-left shunt bypasses the pulmonary capillary filter, which normally filters out microemboli and bacteria. Consequently, thrombi or bacteria can cross directly into the systemic circulation, leading to paradoxical embolic stroke or brain abscess.
Specify the key safety precautions and treatment threshold in these patients.
All intravenous lines must have air filters to prevent paradoxical embolization. Lifetime antibiotic prophylaxis is mandatory before dental or invasive procedures. Intervention with coil embolization is indicated if the feeding artery diameter measures 2 to 3 millimeters or larger. I would recommend referring the patient to interventional radiology. Refer to interventional radiology.